Well, good afternoon, everyone, and welcome to our webinar, the Illinois Prescription Monitoring Program, a clinical tool in improving prescribing decisions. I'm David Porter. I'm the Vice President of Health Policy at the Illinois State Medical Society, and we are honored today to have with us the outgoing Clinical Director of the Illinois Prescription Monitoring Program, Randy Malin. Welcome, Randy.
Thank you, David.
I'd like to take a quick moment to thank the ISME Mutual Insurance Company for their assistance in producing this program, and we welcome any and all ISME insureds who may be in our audience. Most of us are all too aware of the current opioid epidemic. I think it's important to point out that the challenge for policymakers is to develop and implement systems that help prescribers identify potential cases of misuse and diversion while still allowing for appropriate prescribing of opioids for pain control if necessary. And this is where our prescription monitoring program can be an excellent clinical support tool for prescribers of controlled substances. Now more than ever, healthcare professionals need to have a complete picture of what medications are being prescribed and dispensed to their patients, and that's why it's crucial that all prescribers take time to register for and use the PMP as part of their regular workflow in their practice. At the end of the presentation today, we will have time to answer questions, and know that the webinar platform allows participants to answer and to submit questions. We will try to answer all of the questions submitted following Randy's presentation. If for some reason we don't get to your specific question, I promise that I will consult with Randy and that I will personally follow up with you to make sure that all of our questions are answered. So with that, I'd like to turn this over to the Clinical Director of the PMP, Randy Malin.
Thank you, David. As David alluded earlier, I am retiring at the end of this month, and very fortunate to have been able to bring my successor along to listen in to what I'm saying and to make sure that I don't make any promises that she can't fulfill. It's really appropriate that one of the last pieces of my tenure is with the ISMS, because ISMS has been a wonderful collaborative partner that has assisted me throughout the entire course of the design, development, and implementation of the prescription monitoring program. Hopefully, the participants today will be able to summarize the function of the Illinois Prescription Monitoring Program and how physicians can use the system to track controlled substance prescriptions of their patients, recognize clinical issues associated with opioid medications and anxiolytics, as well as smooth muscle relaxants. Hopefully you will also be able to discuss some of the changes to the Illinois Controlled Substance Act, R720 ILCS 570, and see how the use can help safeguard the practice of medicine. One of the facts that a lot of people are not familiar with is Illinois historically has been in the forefront of tracking and monitoring the uses of medication. The earliest predecessor to the PMP was actually initiated in 1958 by the Illinois State Police, and numerous follow-ups and evolutionary changes had correspondingly happened until the reorganization of human service entities within the state of Illinois in 1997, when we inherited the old triplicate prescription program. One of the issues that we found at that point was the fact that only about 300,000 prescriptions were being tracked on an annualized basis, and they were 6 months behind in doing any order entry as far as tracking it. So consequently, when we started to move in the direction of automating the reporting activity, we ended up having a little bit of pushback from pharmacy as well as from some clinicians, because they didn't want to lose their security blanket, the triplicate prescription. even though we had reported one year something like 2,600 prescription pads being stolen. So the triplicate prescription program was not really a good clinical tool. It was absolutely kind of an obstruction to access to care. One of the things that we tried to do was coming up with a definition of what is good faith. What I was referring to when we came up with this idea of a definition was basically alluding to the standard of care. If a clinician was following the standard of care and documenting the reason the patient came in to see them, the results of their physical examination of that client, and then a brief summary of their decision process in coming up with their clinical intervention, along with benefit to risk rationale and a goal for the outcome of that patient and any subsequent criteria for follow-up. As long as a clinician met those standards, then they were compliant with good faith. With regard to a pharmacist, because they are equally responsible, did it make sense? Was this a medication that seemed to be used as a standard of clinical care for the type of symptomatology that the patient presented? Are the doses within reasonable guidelines? Was the strength and quantity also reasonable? Was the distance that the patient traveled to see the clinician, taking into consideration the clinician's specialty, was that reasonable? Was it reasonable, the distance between the pharmacy and there? All of this plays a part in coming up with addressing the good faith effort. Now, relative to that, we then get into looking at a comparator with the Federal Controlled Substance Act, and specifically 21 CFR Section 1306.04, where it basically indicates that for a controlled substance prescription to be effective, it has to be issued for a legitimate medical purpose by an individual practitioner in the setting and usual course of their professional practice, i.e. standard of care. It also indicates that there's a compounding responsibility on the pharmacist to ensure reasonable rationale for the types of medication and how it's used. So we actually have the state law and the federal law actually saying the same thing, which always helps, especially if they agree. You know, it's not too good if they don't. As we look at the Controlled Substance Act, we saw federally that in the mid-2009 year, they issued some proposed language with regard to electronic prescribing. And they followed through with additional rules and definitions in late 2009, early 2010. We tried to emulate where they were going when we had a chance to go in and update the Controlled Substance Act. Consequently, it led to the development of Section 311.5, where it says that electronic prescribing of controlled substances is allowable in Illinois as long as the controls on the prescribing and the security on the prescribing meet the criteria set forth in 21 CFR, actually Section 1311 or Parts 1311. That actually gets into the meat and potatoes of the requirement for the prescribing, including the two-factor identification and security, as well as the criteria for pharmacies and pharmacy systems to receive that type of an electronic transmittal. Okay, let's see if, come on, there we go. About the same time, 2010, 2011, we were getting a lot of questions from U.S. Justice Department because we had applied for and received a couple of Harold Rogers grants. And they were starting to ask about what were the incidents that we were seeing of individual patients seeing multiple prescribers, multiple pharmacies in a 30-day period. And we initially went in and asked for the establishment of Section 314.5, which actually talks about now 331, where initially we were looking at 661. The issue with 331, as you can probably imagine, we ended up seeing thousands of individual names come up as far as patients. So luckily it says the PMP may issue unsolicited letters. And what we have done is we have gone to great extent to ensure that we only send out unsolicited letters where we have a question that the number of prescribers was unreasonable. One of the things I will point out to the audience is that if you haven't enrolled and you do enroll, please indicate if you're part of a group practice, because one of the things that we found was that the primary physician may have written an order for a product. Their APN may have written a different prescription for another issue, or the PA may have stepped in, or the partner in the group practice may have stepped in. And it's conceivable that someone could have received in the 30-day period 3 or more prescriptions for various types of controlled substances. So instead of just arbitrarily, bureaucratically following a numeric indicator, we have actually been attempting over the years to use some clinical thought in, is this reasonable, isn't it reasonable, and why bother somebody if it's a reasonable process. So one of the things that transpired that changed the Controlled Substance Act most recently was the passage of Public Act 99-0480, otherwise known as House Bill 1 or the Opioid Heroin Task Force Bill. And part of the change was that it required the department to come up with an administrative rule on how to integrate electronically EHRs from our pilot grouping volunteers with the PMP so that it was a seamless electronic interface. And quite honestly, this is probably the ideal way to do it, because it becomes then part of the clinical practice, where when you bring up the EHR, you actually have it readily sitting there, and it's always there. So you don't have to remember another login. As long as you can remember your login to your EHR, you're fine. But one of the things that we need to raise is the fact that there are some current pieces of legislation that is going to change or could change that requirement, where instead of the pilot EHRs, It says all EHRs, and it's by January the 1st, 2021. That would be a significant requirement, because you would then have to start checking with your software vendors to make sure that your Office software is compliant with that. It didn't advance. Oh, there it goes. One of the things that I really want to raise is that there is an issue where some individuals have called and asked, well, if we dispense samples or if we dispense meds from the office, do we have to report them? The answer is yes. If you are dispensing more than a 72-hour supply of controlled substances, you are expected to follow the same criteria as if you were a pharmacy. You have to report certain elements, then you can see it in the Controlled Substance Act, relative to the drug, the strength, the dosage form, the quantity, the estimated time frame that it covered, the patient's name and address, and naturally the DEA number of the prescriber/dispenser. Okay, come on, one more. There we go. One of the changes that also transpired under Public Act 99-480 deals with the designee issue. And Section 318 of the Controlled Substance Act includes that language. One of the other things that it does contain is the fact that all prescribers, physicians, dentists, veterinarians, APNs, PAs, optometrists, who are prescribing controlled substances and have a state of Illinois controlled substance license must enroll in the PMP on the renewal of that Illinois controlled substance license. We will come to a slide a little bit later that will show you where you can find how to connect to that. One of the other factors that I probably should bring to the forefront currently is that in January of 2015, IDFPR issued an administrative rule, which was 3100.85, which deals with the application for mid-level practitioner controlled substance licenses. In the context of that administrative rule, they have gone on to indicate that the collaborating physician who has collaborative practice agreements and collaborative supervisory agreements must enroll in the PMP and must enter those collaborative practice agreements in a system set forth by the PMP program. Well, we didn't get our administrative rules done until late part of April of 2015, because this kind of caught us a little bit by surprise. But it is there. It can be very beneficial for us in the evaluation of the prescribing to make sure that the individual is part of a group practice or that there is a collaborative practice agreement, in which case instead of assuming multiple prescribers, it would be all attributable to one. Okay, come on. Well, that time I got too many. Okay. One of the other issues that I'd like to bring up is the simple fact that we would like to have on those individuals who are currently enrolled, if you are updating your base profile, especially if you had changed your email address, because some of the criteria in the current Practices Act requires us to send out electronic information, and it's a little hard to get those changes to you if you have changed your email address. It just kind of goes nowhere. So all we ask is just kind of help us stay on top of what's going on. As part of the Act, we have been able to, or we were directed to set up a very formal advisory committee. We had always had one before, which was kind of a very loose-knit advisory committee made up of all of the associations representing those entities that could either prescribe or dispense controlled substances. We now have a criteria that we are following with regard to Section 320 of the Controlled Substance Act that actually mandates 4 physicians, 3 pharmacists, 1 dentist, 1 podiatric physician, 1 optometrist, an advanced practice nurse, and a physician's assistant. We have expended quite a bit of effort to ensure that these individuals representing the various professions that can prescribe cover the breadth of the state. Some of the members are from the southern part, some of the members are from the northern part and the center, as well as even the Peoria area. Relative to the dentist, we reached out and were able to get a hold of an oral-facial maxillary surgeon. And so we're trying to make sure that every one of the members of the advisory committee are active clinicians, that they are seeing patients, that they are dealing with the day-to-day problems of compliance with the intent of the Controlled Substance Act. So it seems to have worked extremely well. I have been very, very, very pleased with their interaction, as well as their assuming ownership of where we're going with the prescription monitoring program and how we can address making it easier to use as well as to move us forward. As part of the mandatory requirement for the advisory committee, the Section 320 also requires the clinical director to establish a 5-member subcommittee. That's the peer review committee. And we have done so, and we have been slowly but surely working on evaluating how are we going to look at prescribing. We have agreed that we are not going to 100% rely on the CDC guidelines. Those are going to be the base from which we start. You'll also find it interesting that the group had identified the fact that some of the specialty areas would have to be looked at relative to their own standing. As it turns out, DEA is now saying that oncologists are separate from this criteria that they had put out. We also believe that interactive palliative care is also another area that, especially on subsequent ongoing utilization, needs to be looked at within its own criteria. There we go. For those of you who have not enrolled, if you go out to, on your search engine, ILPMP, and hit enter, it'll bring up a series of Illinois prescription monitoring sites. Go to the home page, and the current screen is reflective of the home page. And if you notice at the top, there are some criteria that if you click on them, they're a drop-down menu. The first section to the left of the slide, if you click on it, there is a section in it that has a video that will tell you how to use the PMP. There are also point-click drop-down menus such as drug treatment that will give you a link to SAMHSA so that you can look to see what kind of programs are available around your general area. You can also, if you decide you need, there's a law enforcement connectivity as well as a criteria for the federal DEA practice area that includes the practitioner's manual as well as the pharmacist dispensing manual. If you notice, we've highlighted a section which is prescriber registry. If you click on it, it will give you this very next page, which even with my bifocals I can't read right now. So I would suggest that after this webinar is over, go out to Illinois PMP, click on prescriber registrant, and then it should be large enough that you can read it. Basically, what it covers is, as starting at the top, we want to know your email address. We then ask you to enter it a second time to make sure that it's correct. And then you pick the password that you want to use. I would suggest you write it down because some people, when the office staff contact them to give them their sign-in and that they can't remember their password. But it's basically filling in the demographics. Also, what kind of practice. We're looking at changing that so it more readily reflects the taxonomy of the physicians that are practicing there. It currently says mid-level practitioner. We're going to separate that out to APN as well as PA. If you get down to the larger white box, it's basically the use of the prescription information library is intended for and may only be used for a medical purpose. Basically, you are giving the prescription monitoring program and its representatives permission to contact you through the contact information you're providing to allow for validation of submitted information. We actually will go out and call the practice site based upon the phone number we can get from the internet, just to make sure that somebody isn't kind of leading us astray. We also indicate that in filling this out that you are accepting the responsibility for the access that is attributable to your assigned login. Because if we go to the next screen, once you have enrolled and once the staff have contacted you and validated all of your information and talked to you about your sign-in, you will then fill in this information that's in the highlighted yellow. And if you notice, there's a third entity that you have to fill in. And it's an alphanumeric code that changes every time you enter or you bring the screen up. What this does is it does log you into the system. We know who came in using that ID at that time and what they looked up. I will also point out to you, you might want to inform your office staff. We do kind of look to see if people are looking up Oprah Winfrey or the president or the mayor of Chicago or Springfield or whomever, because that is basically, unless you're providing health care services to them, a violation of HIPAA. And we have pulled some individuals' access. So if you fill all of this out and you log in correctly, you should end up getting a screen similar to what is currently there. One of the things that we did based upon the recommendations of the end users was they said, well, we want to know if a patient attributed to us is in fact apparently going to multiple prescribers and our dispensers. So if you notice, just above the section that has very dark column headings, it says patients with potential abuse indicators. Now, initially this meant 661. We also, in the narrative underneath that heading, indicate that it's up to, we are not making a clinical judgment. It's up to the clinician to look at the profile of their patient to make the determination if they need to even talk to their patient about multiple entries. So if you are interested in following it, if you'll notice, it says View Patient. So if you click on it, you're going to get another screen that says, do you want to include other states? In which case, you can make that determination. I will tell you that we have like 15 other states that are part of the PMPI, which is with the National Board of Pharmacy, and it allows for selected interfaces with those states who have similar administrative rules and statutes, so that if another state has a statute that authorizes state police or whomever to search, we do not have a direct interface with them. We're currently working on developing a simple check covering all of the collar states around Illinois, except our neighbor to the south, Missouri. They still do not have a PMP. And a couple of the other PMPs are in various stages of interfacing and development. So that should kind of give you a little bit of an idea about it. And then once you made your selection, you then hit enter. And this slide gives you a depiction of a search that includes Illinois and Wisconsin. And one of the columns says state, and you'll see the abbreviation for Wisconsin, R for Illinois. The staff, since we actually never created a basically training program, ended up going in and doctoring this up, and they are a little bit taken with Sherlock Holmes because the patient's name is Sherlock Holmes and Dr. Moriarty and all of that. But the interesting thing is it will tell you the name of the drug, it'll tell you the quantity dispensed, and the estimated time that that prescription would cover. And if you click on one of those, you will see that you will get a summary that will tell you the demographics about the patient, the prescriber, and the product, as well as the dispensing. So from a drug reconciliation standpoint, if an individual was brought in and was not able to communicate with the emergency room staff, you actually would have a methodology of identifying someone who has provided care to this individual, and at least make an initial contact to find out any additional information that might be out there. If you go back in and just log in, one of the other questions that a lot of the end users have had is, can you give me a printout of what I have prescribed, or prescriptions that are attributed to me? So we actually created that. So if you click on it, it will come back and show you your prescriptions, and you can then sort it by patient, you can sort it by drug, you can sort it by time of the prescribing. I strongly recommend that the end users actually avail themselves of this program. We have had a number of times where practitioners have called me and have indicated to me, this is not my prescription. And what happens when we went in and started digging through to find out what happened, sometimes pharmacies that are in a rush with the point-click drop-down menu will initially think they're clicking on John Jones, and just a twitch of their hand, and instead of John Jones, you have Jameis Jones. Well, that could be the difference between an OBGYN writing an order for a pediatric patient. So it avails you to look at this very closely. We've actually created administrative rules that set up the criteria so we can actually go in under these rules and reverse those activities. So we are attempting to provide tools that help the individual practitioner manage their practice, or at least provide some checks and balances for their practice. If you notice on this slide, we've highlighted PMP News. If you highlight it and hit enter, you will see what we are putting on the website relative to any changes. Normally what we will do is we'll use this site for changes to the Controlled Substances Act, both federally as well as state, to give you some idea of what is transpiring. Now, granted, you're probably getting the same information from your association, but it never hurts to have multiples. This is our contact information. One of the things that I've been doing over the last few years is tracking the registrations and looking at the prescribers that, as well as pharmacists that are applying for the use of the system. Currently, we have somewhere around 30,000 registered users. 9,000 are pharmacists. The next grouping that is a higher utilization are physicians. The reason you see two spikes The first spike to the left was when Walmart mandated that their pharmacists were going to enroll in the system and use it. The huge spike was when Walgreens did. Now, based upon 99-480 and the fact that we are in the middle of the renewal process for licenses, those clinicians that have renewals that are transpiring in July, one should expect to see a spike. And I believe it's the physicians that are currently in the renewal process. So I'm expecting to see, and Sarah is going to see or evaluate, do we have a corresponding spike? Give you some idea of some of the activity that the advisory committee and the peer review did. We looked at, some time ago, we looked at the top 100 consumers, and we then started breaking it out within regional utilizations, which was kind of interesting. We then separated out Cook County from the northern region. And one of the interesting things with the prefixes of licenses is the fact that it allows you to go in and identify who's who as far as prescribing. We have designed and developed some spreadsheets that we are currently using with the peer review committee, and we are literally looking within public health regions the top 200 prescribers of opioids. We're breaking it out within the specialties listed here, and for physicians and DOs, we then take it even further down and look at the taxonomy of those prescribers. So we are comparing apples to apples. And it's proving to be kind of interesting. We also have been tracking the fact that 57 prescribers have appeared on 4 of 4 months' worth of reports. 455 prescribers have hit on 3 of 4 months' reports, and 265 have hit on 2 of 4 months' reports. And what's interesting is, if my math is correct, that's 777 practitioners that we are tracking. And that's from a base that we kind of developed of 7,868 patients. What is really interesting is that when we look at the top 250 patients as far as multiple prescribers and multiple dispensers, those top 250, when you look at 12 months utilization rate, there were 3,866 prescribers. And believe me, Sarah and my eyes felt like they were going to fall out of our heads as we were going through trying to evaluate this. And this then is just a simple descriptor or a sample distribution of how we are going to be looking at these issues, where we're separating out the dentist and all of the different prescriber activities. And as I promised, this slide actually is the last screen you see when you're electronically renewing your license with IDFPR. If you look at the very last line, holders of Illinois Controlled Substance licenses may create a profile with the Illinois Prescription Monitoring Program at, and then the website. Now, if you notice, it's very, very small font. It's probably because we didn't give them a nickel to put it on there for us. So, in closing, what are the considerations? Be familiar with evidence-based acute care practice. Use the PMP to verify pharmacotherapy histories. Keep current with the changes in state and federal controlled substance acts. evaluate the patient, with the patient, the true need for opioids. If dispensing a 72-hour supply of any controlled substance, it must be reported to the PMP. If the patient is a referral, determine if he or she was prescribed medications prior to your office visit. Ascertain in your own mind if they should have any medication left over from that previous visit, and then adjust accordingly. Check for benzodiazepine prescriptions prior to dispensing or prescribing an opioid. About roughly 30+% of combination therapies can result in adverse events. And with that, I'm done.
Not yet, you're not. We've got some questions.
Oh, shoot.
Well, first of all, thank you very much. I very much appreciate that. And I do have a bunch of questions here that I'd like to ask, and I'll try to group them so it's not seemingly all over the map. Let's start with enrollment, some enrollment questions about enrolling in the PMP. Several doctors have told us that they have, as part of their license renewal, talked to the Illinois Department of Financial and Professional Regulation, but nobody at that end of the phone has told them or reminded them that they are required to enroll in the PMP. The burden, as I understand it, is on the physician to then go and enroll in the PMP. Is that correct?
Yes, because the statute is pretty clear.
And the process is that they would go to your website as you described and fill that out, and that they have to confirm that with a phone call afterward with someone from the PMP staff, or is it all automated?
No, our staff confirms it with them.
The staff is the PMP staff follows up with the enrollee to confirm.
What we normally do is we'll go in and check to make sure that we have the legitimate license number. We have the information as far as where the individual works. We actually go so far as to have staff call that practice number and validate that the clinician that has applied is actually employed there or works there.
So you made reference when logging into the requirement for an alphanumeric code. Would the PMP staff provide that alphanumeric code?
Well, they provide the user ID, and then actually in the process of registering, the applicant gives us the password that they want to use initially.
Okay.
And then every time they log in, there is an alphanumeric third entry that they have to make before they hit log in, and it is case specific. So if it is a small case number, use the small case. Otherwise, you're going to be really frustrated because you're not going to get in.
So prescribers also have the capability to designate someone who can check the PMP on their behalf, correct?
Correct. And actually, we have a proposed administrative rule that is working its way through JCAR that sets the criteria for the designees.
Does the designee have to be a licensed healthcare professional?
Yes.
Yes. So it has to be a nurse or a physician assistant or someone like that.
Yeah. I think there's another one. One of the institutions had talked to us about a certified something where there is a place where you can go and validate the individual has met the criteria.
So there is for example, a medical assistant who's not a licensed professional could become certified at some point to be a designee or something. In a given practice, for example, can one person be the designee for example, 5 prescribers? So that
if it's a group practice, why not?
Okay, so there's no limits. So if there's 10 doctors in a practice, they can all designate their PA to check the PMP on their behalf.
Sure.
Yeah. Okay, so a single person can do that. Okay, so let me ask some other questions about data you were talking about. You indicated that you recommended that prescribers go and look at the prescribing history of a given patient. Could I go in, for example, and see prescribing histories for all my patients? If I could search under my name and DEA number, I'm going to get a list of all my patients and what they've been prescribed and dispensed over a given period, for example.
Yeah, because actually one of the slides that I alluded to is, my prescriptions, and it will literally go back and give you a year's worth of data on you.
Right.
Now, granted,
it could be a lot, right?
It might be a couple of days off, or a day or 2 days off, because of when you run it. The pharmacies have until the end of the next business day to report to us electronically.
Right.
In which case, if that pharmacy's not open on a Sunday, it's going to be like Monday. So there could be that
little lag time.
Little lag time.
So what's in the PMP is information that is reported by pharmacies, that which has been dispensed to the patient, correct?
Correct.
So what types of medications are reported by pharmacies?
All Schedule 2 through 5s.
Does that include medication-assisted therapies like Suboxone and methadone?
Yes.
And buprenorphine? I can't pronounce it.
Buprenorphine?
Yeah.
Well, in fact, that's an interesting question, because Sarah and I actually kind of stumbled across the fact that a clinician that I know, his numbers seem to be a little off. And I actually contacted him, and lo and behold, I found out that he's enrolled in the office-based waiver program for substance abuse treatment.
Right.
Consequently, his prescriptions for that were rolled into his overall morphine milligram equivalency activity, as well as the number of patients seen. And so one of the issues that the peer review committee and Sarah are going to be working on is being able to roll these out and actually create a table that will allow us to pull those concomitant therapies out, because they're being used to treat that patient, not for pain, but for
addiction. Right. So when you talked about this 4 for 4 and 3 for 4 and 2 for 4 as part of tracking, and you indicated that you don't necessarily rely solely on the CDC guidelines for the treatment of chronic pain. Are there some standardized guidelines that you are looking at to evaluate prescribers?
We're actually looking at incorporating some of the national algorithms and national standards of some of the specialty groups. Right now, we're basically laying the foundation. It's taken us a little bit of time, as you can guess, to get the plethora of members of the advisory committee and the peer review to agree upon how are we going to approach this.
Right.
And we have moved extremely forward. We have extremely interactive members who are taking and looking at this data that we're sending them and analyzing it, and actually sending requests back for us to pull the data in a different way. So I look at it that we are finishing basically establishing a year's worth of foundation of data that will be used longitudinally to continue the review and to come up with standardization within taxonomies of the clinicians.
And have you initiated any interventions with outlier prescribers?
Actually, we have been sitting down and no, we have not individualized at this point, because there are too many questions.
Right.
I personally feel that if we inhibit one patient from receiving proper pain management, we have failed. So I have been very careful and very conservative in our initial activity.
If I'm a enrolled prescriber in the PMP, is there a way for me to compare my prescribing habits against one of my peers who might be in the same geographic area and the same medical specialty?
Where we're planning on going with this is as we refine these spreadsheets within geographic areas, it has been our goal that we will have a statewide analysis saying here's the average within, say, oncology. And here's where each of the public health regions fit. And then the individual would be able to run their own report and determine themselves where do they fit. Now, granted, if they are a significant outlier, they're probably going to get a letter from Sarah.
Right, as part of the peer review process.
That's right.
Right. A lot of physicians call me and say that they want to prescribe controlled substances electronically, but they are having a hard time doing so.
What I
would some guidance or advice that you
yeah,
give
what I would
physicians?
suggest is that they contact their software vendor and see if they are ask them to provide them with information with regard to compliance to 21 CFR Part 1311.
That's pretty good, right off the top of your head. The other question that we get a lot at the Medical Society is what I'd like to integrate the PMP into my electronic medical record because outside of the electronic medical record, it's a little cumbersome and time-consuming, but inside the EHR or the EMR, it can be incredibly efficient.
It's a fraction of a second.
What should practices do if they want to try to integrate the PMP into their EHR?
First of all, talk to their vendor.
Right.
And then if, find out, they'll want to find out what it's going to cost them. The fact is that by January 1st, 2021, the vendors are going to have to interface. Right. So,
but that could be a cost to a medical practice, correct?
That's why I'm suggesting that they talk to them.
They get started now.
Right.
Right.
Because actually you guys may be able to negotiate on behalf of larger groups to get better prices.
That's a great idea. And then, outside of an electronic medical record, physicians say that it can be a cumbersome tool because it logs you out too quickly. So if I deal with a patient and then I come back 20 minutes later with a new patient, I'm already logged out. I've got to relog back in.
That's a security issue.
That's a privacy security issue.
Right. Now, what I would recommend is if you have a list of the patients that are going to be in the next day,
right,
have your designee in your office pull the current reports and include it in their file if you're still using manual files.
Before the clinical interaction, have
right.
somebody pull all your patients expected
right.
to come into the office the next day.
Yeah.
That's great. One questioner asked, other than prescribers and their designees, who else has access to the data in the PMP?
Pharmacists and the members of the PMP staff.
And nobody outside of that?
The only thing that we will do is if IDFPR or if law enforcement asks for a criteria or a report, they have to submit certain documentation and then we run it internally. Also, there's a section that indicates that the clinical director is the one who makes the determination, is this appropriate?
The clinical director being you. Right.
Sarah.
And now Sarah. Right.
Yeah.
Well, Randy, first of all, I very much thank you for your willingness to come here and do this presentation. We've run out of time, and I've told our listeners that if they have additional questions, that I will make sure to respond to any and all questions that have come in that have not been answered yet. So if you asked a question and it hasn't been answered yet, I will get back to you. So I want to thank you. I want to congratulate you on the incredible work you've done for the prescription monitoring program, and to wish you well in retirement. And we've enjoyed very much working with you, and we very much look forward to working with Sarah, the new clinical director. So with that, I want to say thank you to everyone who's participated, and know that I will get to your questions, and to enjoy the rest of your day. Thank you very much for joining us.